Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case, a typical example of low-grade follicular lymphoma. So this is a 55-year-old male patient who noticed to have an enlarged cervical lymph node, and so it was excised. And as you can see from the low power magnification, there is total effacement of the lymph node architecture with replacement by variably sized nodules, but even from the low power magnification, they all look like similar, as if they are all composed of the same tumor cells. And really, there is no well-defined starry-sky appearance as we would see usually in reactive lymphoid follicles. Now, on a slightly high power magnification, this is the lymphoid follicle where all the tumor cells more or less resemble each other without really polarization, without dark zones and light zones, as we would encounter in reactive hyperplasia or lymphoid follicles. And again, here at slightly higher power magnification, we see the same, not much on the way of mitosis. There isn't much mitotic activity, just scattered cells. These are usually follicular dendritic cells. These are not the tingible body macrophages. And on oil immersion, you can see here the composition of the tumor with some cells with a prominent nucleoli, fascicular nuclei. This is consistent with a centroblast, the smaller cells, the cleaved cells without a prominent nucleolus with condensed chromatin. This is the typical appearance are the centrocytes. So we have like a mixture of centrocytes and centroblasts in the absence of easily identifiable mitotic activities, as well as in the absence of tingible body macrophages. This is the typical composition of a low-grade lymphoma. Now we're resorting to immunohistochemistry, as you can see with CD20 beautifully highlighting the follicles or the nodules with the diffuse cytoplasm CD20 positivity that is further highlighted cytoplasmic immunostain, and the CD3 showing some CD3 positive cells, the T lymphocytes just at the periphery in the internodular areas. And of course, we know that there are always some scattered CD3 positive cells within the follicles. BCL2 beautifully positive, strongly positive. These are the follicles and these are the interfollicular area. We know that in normal reactive conditions, the interfollicular areas, which are usually the CD3 positive areas, are usually positive with BCL2, whereas reactive lymphoid follicles are usually negative. When you see this reversal where we have a strong positivity with BCL2 in the lymphoid follicles with negative interfollicular or with weaker staining with in the interfollicular area, this is really very supportive of a follicular lymphoma. And as you can see here, this is the follicle, and this is the interfollicular area, stronger in the follicle than in the interfollicular area. Also CD10 beautifully strongly positive. Now there is an important tip. CD10 is usually positive but weakly positive in reactive lymphoid follicles, whereas CD10 is usually strongly positive, diffusely positive in low-grade lymphoma, follicular lymphoma. And this is an important tip to pay attention to, and this is the higher power magnification. And then the BCL6 again is positive within the follicle. Does not really help to differentiate between the benign and malignant, unlike the CD10, which is strongly usually positive in the malignant versus the reactive lymphoid follicles. And the Ki-67, extremely important, because the Ki-67 in reactive conditions would show polarization where we have more positivity in one side of the follicle against the other area, whereas in the malignant conditions we have even distribution of the immune stain throughout the follicle, and again the Ki-67 on high power magnification. So previously, when before the era of immunohistochemistry, we used to do reticulin, where the reticulin stain the fibers would be positive in the interfollicular areas, whereas it's usually negative or lost in the follicles, very much similar to the desmoplastic nodular medulloblastoma. So the final diagnosis in this case is a classical follicular lymphoma, low grade. Nowadays, the WHO really does not recommend differentiating grade 1 from grade 2 or 3A, because ultimately the prognosis and the outcome is similar and the patients are treated in a similar fashion. What is very important is to pay attention for the presence or absence of any diffuse areas of growth versus the follicular areas of growth, as in this case, and always pay attention to the immunohistochemical stains, the distribution of the Ki-67, the positivity with BCL2, and the strong positivity with CD10, because these would strongly support the diagnosis of follicular lymphoma versus reactive conditions. I hope you find this tip useful in your daily practice. Thank you.